Recording. All right. So article number 1, the Traverse study. So this is a trial of testosterone replacement therapy, and it was just published a couple of months ago or a few months ago in the New England Journal of Medicine. So just a bit of background on TRT and why it's important for this conversation. So there's good evidence that TRT does have beneficial effects, including improving lipids, improving insulin sensitivity, and body composition specifically. So obviously testosterone promotes lean body mass development and fat mass loss. So exactly what you want in a patient who's obese but under-muscled. There are, of course, some known risks for testosterone replacement, including it will increase your PSA and it will increase your hematocrit. So both of those things need to be monitored for patients who are taking it. And then there may be an increased risk of venous thromboembolism as well. However, when it comes to cardiovascular risk, the data has really been mixed and not conclusive. But I guess concerning enough to the extent that in 2015, the FDA actually issued a requirement for the manufacturers and the pharmaceutical companies to actually test this question. So, because I think otherwise it was going to be a black box warning. And so they said, you just need to do a proper trial so that we know for sure. So that's exactly what Traverse is. And then just a note about under and overuse of TRT. So it's probably significantly underused in the population who could really benefit from it. So that would be our obese patients with metabolic syndrome, et cetera, who have hypogonadism. And so I don't think that many of us think about even checking a testosterone, let alone replacing it. And that's a major gap in care. But then it's also overused. And this is part of the issue as well, is there's like a whole cottage industry out there of using testosterone replacement for, young men who just want to increase muscle mass with super physiologic doses. But then also just, men who are in their middle age and they're just kind of like tired and sad, and somebody's happy to give them a prescription for testosterone to try to fix those problems. So we're kind of probably misaligning who is going to benefit from this most. Okay, to the study. So in terms of the protocol, the patients, so this is a phase 4 trial, so it's a post-marketing trial, obviously. Men between ages of 45 and 80, they had to have at least one symptom of hypogonadism. So the top tier symptoms are decreased libido or a reduction in spontaneous erections or erectile dysfunction. But then they also included in that the sort of second tier symptoms of like fatigue and brain fog and sort of non-specific things. But they did have to have 2 fasting testosterone levels below 10.4 nanomolar, which based on the labs that we have locally would line up nicely with probably low total testosterone levels. And that's in keeping with the guidelines. So you need to repeat it and make sure that it's low a second time. And the patients either had to have established cardiovascular disease or be high risk for it based on 3 or more standard risk factors. So definitely a high risk population. They excluded people with congenital low testosterone, obviously patients with prostate cancer and nodules or elevated PSA, anybody who'd had a history of thrombophilia or significant clots, and then, and then anybody who'd had a recent ACS stroke or stenting, because this is going to be the primary outcome. So those patients are gone, and I think that's appropriate. In terms of the intervention, what they actually use, so they use the Androgel 1.62% formulation. So not sure why exactly they chose the gel form of testosterone replacement, and that's something we can talk about at the end. But they checked testosterone levels throughout and targeted serum levels between 12 and 26. So that's kind of right in the middle zone of the normal range. So they didn't want high end or supra physiologic levels. And then if you had a hematocrit that crept up above 55%, they would lower it. This was all done centrally by a computer algorithm, because who needs humans anymore? And then the nice thing about what they did with the blinding, so it was compared to placebo gel, but they actually did sham adjustments with the placebo gel as well. So you wouldn't know whether or not it was being adjusted because you were on treatment or not. Their outcomes, pretty standard. So this is set up as a non-inferiority safety trial. So they weren't trying to demonstrate a superior benefit. It was all safety endpoints. So they looked at major adverse cardiac events as their primary outcome. So that's the standard MACE basket of things, in a time to event analysis based on Cox proportional hazards, which I think is an appropriate statistical test for this study question. Secondary outcomes was MACE plus anybody who went for like a revasc, stent, or CABG for, I guess, stable or advanced coronary disease. And then their tertiary was a big long list of things that included all-cause mortality, hospitalization, basically anything else they could think of that would be a problem that people would come up with. And then they also tracked a bunch of non-cardiovascular outcomes. And these would actually be the things that we're interested in as practitioners, such as what happened to your blood sugar levels and your insulin levels and your blood pressure, et cetera. So all of the important outcomes that we're actually looking for benefits. So they list those in their supplements, but they don't actually report the numbers because they're going to publish those in future studies. So they don't share that information freely, which is cagey, but, you know, reasonable, I guess. Okay, so what did we actually find out? So first of all, the treatment did actually have a physiologic effect. So here we're just looking at what happened to testosterone levels. So right out of the gate, you know, within a month or two of randomization, patients on treatment did have significantly higher testosterone levels over the entire course of the study period. So that's great. So it means we are actually comparing groups that have a difference biologically. This is their primary event thing. I didn't even worry about showing you the whole thing because every box basically shows you exactly the same stuff. So in terms of their primary outcomes, so this is now just the chart of their hazard ratios. But all this is to say that there's no statistical difference in either their primary or their secondary outcomes of interest. This box D that looks at death from cardiovascular cause, it looks like there's a bit of a separation of the lines there, not statistically significant. But what they also mention is that because this was a non-inferiority trial and they don't adjust their data for multiplicity. So if you have patients that have multiple events potentially, then that's not taken into consideration. And so you can't actually infer from this that there might be a potential benefit in the case of cardiovascular death favoring testosterone. In terms of who actually made it into the trial, so it's exactly the people that you think. It's men in their mid-60s who are obese with a BMI average of about 34 or 35. I think about 80% of the population is Caucasian, lots of diabetes, hypertension, and dyslipidemia. So exactly the population that many of us see on a day-to-day basis for either prevention or secondary treatment of cardiovascular disease. And there were no baseline differences between groups. So for their endpoints, again, we don't see any significant differences. So all of their hazard ratios reported all cross 1, meaning there's no change in primary or secondary. It's only once we get down to the tertiary endpoints that it gets a little more interesting in terms of, is this a problem or not? So for venous thromboembolic events, it's not significant, but it's sort of skewing towards harm. And then down here, they report specifically PEs happened in 0.9% of the treatment group, 0.5% of the control group. But of course, they don't add statistics to these because these were the components of the pooled VTE group. So we don't actually ultimately know what that means. And then the final adverse events that they reported, the things to highlight here are there was a statistically significant increase risk of non-fatal arrhythmias in the testosterone group. absolute difference is, just shy of 2%. So a number needed to harm of 50. And most of that is atrial fibrillation. So that's interesting because that's actually, I don't think, something that was on the radar, although the absolute numbers are pretty small. And then acute kidney injury also had a significant increase in risk as well. Although, again, small numbers that we're talking about. So their study conclusion was that men with hypogonadism who are high risk for cardiovascular disease, testosterone replacement is non-inferior to placebo in terms of MACE. So I think that's actually a reasonable conclusion to make based on the data that they showed, which leads us to the actual appraisal of it. So in terms of the validity of the results, so the randomization and the blinding, I think, were actually quite adequate, especially with the sham control using the gel formulation. That I think that was done in a reasonable fashion. So the groups were actually treated equally, except for the intervention itself. One problem arose that the enrollment criteria was actually changed after 1 year. So this was pre-specified, but they did have to enact it. So what they found is that their event rate was not going to be high enough to run the trial in a reasonable period of time. So they changed it to basically eliminate enrolling people on the basis of just high risk, and they only enrolled people with established cardiovascular disease from 1 year onwards. So, it just it always changes the calculus a bit when you have to change your enrollment criteria on the fly. There's also a pretty big issue with missing data in their data set. So the number of people who stopped treatment was pretty substantial. So actually 60% in both groups didn't actually use the treatments for as long as they were supposed to. And then 21% actually withdrew from the trial before they started doing their end of trial assessments. And then 18% made it to the end of trial, but never actually showed up for their appointment. So there's a significant potential lack of data if we want to apply like an intention to treat analysis. They state that they still had about 80% of all data from all people who were randomized to analyze. But that's like right at the threshold where you start to get pretty concerned that there's not actually enough to have an adequately powered result to believe it. So that makes it a little bit dodgy. And then the final thing is the industry funding. So this is, the FDA mandated that the manufacturers had to do this. But of course, it's funded by a consortium of companies. AbbVie was the main sponsor, and they actually say in the body of the article that the group of manufacturers was allowed to review the manuscripts and even suggest revisions to the final manuscript. Although, the final word was allowed to the academic authors. So it just always a little bit shady when you see that written in there. So finally, how do we think about this in terms of our own practices? So in terms of the relevance, I think it's probably reasonable to conclude that there is actually no increased risk of MACE, especially like this. It is a high risk population that they selected for. So you're using it in, at least half of the participants were a secondary prevention population. And on the basis of previously existing data, I would have no issue, I think, using this in somebody with a history of coronary disease and counseling that patient to say, there's no good evidence that there's an increased risk for additional coronary events in your case. The population is definitely typical for what we see. So I think you can for sure generalize that. So lots of obesity, diabetes, hypertension, etc. What gives you a bit of pause is the potential for those adverse effects. So the clots, the AFib, and the non-fatal arrhythmias is probably the major risk that came out of this trial and probably needs to be looked into further. especially with different formulations that potentially are more potent and potentially with higher serum levels of testosterone. So this group, because they were using the gel and it was adjusted to keep them right inside the middle of that normal range, we don't ultimately know if there's additional risk conferred for higher serum levels, which probably a lot of people on TRT have. And then just the poor adherence in general. So I'm not sure why they chose the gel formulation, but there's, a lot of men don't like it. It gets on your clothes. You have to apply it, a couple times a day. It can transfer, so you always have to be careful around other people if you have kids getting exposed to the gel as well. So we have to consider alternatives like sub-Q. Usually stay away from oral dosing, but there are different versions. But ultimately, because they only studied the gel version, we don't necessarily know if we can extrapolate all of this to different formulations of testosterone. And then I think we also need to underscore that we do have to demonstrate somebody has true physiologic hypogonadism before actually offering them this treatment, especially since there are potentially some risks associated with it. So that's all I'm going to say. Happy to open it up to any discussion or questions before Marko's study.
Thanks, Andrew. My one comment, it's interesting, the PE risk is that you've got people, men, who are on antiplatelet agents to begin with, presumably, right? Because they have established coronary disease risk. So the fact that risk is, it looks like it does increase the risk, or it may, is interesting despite the antiplatelet effect, which, presumably would blunt that response.
Yeah.
It's odd. It's interesting.
That's true. I can, from table 1, 60% were on aspirin.
Yeah. Which, it's kind of what would be expected. Even with the AFib, that's that whole interplay between endothelium and clotting factors and humoral factors and all these things, right? The other issue to me, 2 other issues. One, that's insane that they had loss to follow-up for like 20%. Like, that's actually just wild.
So COVID played a role.
Fair. Yeah, and so did the Mind Diet study as well, right?
Because I think the study started in 2018, I think.
Yeah. But when we were doing trials at PHRI, like, anything under 95% is completely unacceptable.
Right.
And you're looking for 99 plus. And like, legit, like, when we were running these studies, we're like looking at ways to contact, like, literally 3 or 4 different ways to contact patients. And then if you can't, you're actually looking at like obituaries and stuff like that as well, like actually do a Google search just to make sure. So that like 80%, even in the setting of COVID, it seems that was high. Obviously challenging, but that was high. Even vital status, and this is the thing, like, if you got a study powered for MACE, it's literally half a phone call, which is hi, you still alive? Check. Have any heart attacks these days? Check. Can you speak from your stroke? Yes, good. But that's the so it's a fairly simple, but yeah, I appreciate the thing. But anywho.
Yeah, Julia had a couple of comments in the box here. Do they have the same outcomes with androgel versus the IM testosterone? Yeah, so we don't know. I think that's part of the issue. I think if you want a really good predictable serum level, then you would opt for the IM or the sub-Q dosing, because that it's getting in there, whereas the gel, it's a bit wishy-washy. And then now with PE risk, could they potentially be travel related? Who knows? They don't report those sort of things. I don't know.
Plane travel, I think, is overstated as a risk factor for thromboembolic disease. Yes, it does happen. However, I think on the whole, it is a very small proportion of, attributable risk for the population overall.
Yeah. Yeah. Any
How
other?
often do you guys prescribe this in clinic?
Personally, not terribly often. When I do intake for a patient for a cardiometabolic health assessment, I do check their serum testosterone on my intake labs. And like, we know that patients who have obesity and metabolic syndrome, they have lower than normal testosterone levels a lot of the time. But it's, to be in a range that's actually replaceable is less often than you think. So it's not terribly often.
Yeah. I mean, personally, the thing that you're going to see in GIM is referrals from family docs with unexplained fatigue. I try not to see those as much as I can. I mean, that's the reality. I refuse second opinions nowadays. And I've been actually sending a lot of them to Stratford, even if they live in London or anywhere else. Hi, Shane. But I mean, I would check it. If you don't see anything, I think in a middle-aged guy over 40, I would check it. Generally, if I found that it was low, I would not follow up, but that would be the purview of the family doctor to. I would flag it as.
But it's also got to be done properly. It needs to be fasting, and it needs to be in the morning, and then it needs to be repeated. So there's some instructions and some steps that need to be done. But just like normal physiology, after age 40, there's about a 10% reduction per decade in testosterone levels. Dr. Narayan has his hand raised.
Thought I'd follow Zoom etiquette, teach you guys a little bit of Zoom etiquette. Marko just bursting in with questions. So a couple things. One, agreed. I think this is neat in that it sort of reduces risk, or at least it suggests maybe no harm in short while. I agree completely that dropout rate is ridiculous and kind of hard to make long-term recommendations with it. Realistically, when testosterone is low, I think there are other clear indicators of like poor sleep and activity that might moderate that in the long run. So it'd be neat to kind of compare it to an exercise intervention, which is proven to have benefit. Good luck with that, Andrew, in the fairy tale world of making physical activity happen. But I've got to say, in the background, there are things like prostate cancer, right? Like long-term risk stuff is probably my bigger concern. Like, there are a lot of people with first-degree relatives who got prostate cancer. It's lower risk. We know PSAs are going up. I think that long-term risk is probably one of my hidden concerns with a relatively short follow-up.
And that's the other practical reality is, if you're a specialist, then if you're putting somebody on TRT, you're kind of committing to following that patient in the long run, right? So you have to think about this as kind of indefinite therapy, that you're going to be checking CBCs every 6 months. You're going to be checking a PSA annually and doing something about it when those metrics move. So if you're just if you're like Marko and you're like a one and done, send it back to primary care, then.
That's right. I don't even leave a note like early. But so my concern, and the biggest, if I was going to say the things, the trials, it's reasonable overall. I think it's reasonably designed. The withdrawal rate's an issue, but the things that I'm concerned, and in terms of the considerations, is that testosterone replacement is lifetime therapy then, right? Really, I mean, you're committing somebody to really potentially in their 40s is literally decades of therapy. Certainly, we do not have evidence in terms of decades. My sense is that in terms of the prostate cancer, cardiovascular disease, erythrocytosis, VT, these types of things, there's probably increased risk. I think it's probably minimal. But there's no evidence one way or another. And, 4 years of follow-up is not sufficient in a 45-year-old man, to really say one way or another. Hopefully they continue this, right? I mean, that's the other thing. Certainly is right as part of the trial. It'll
also be interesting when they report the potential beneficial effects, like the metabolic effects.
I know, and that's the that's the issue.
Because if that's not impressive, then it's like, well, great.
May allow them to get their blue belt in mixed martial arts.
I mean, so Chanel, you know, as you alluded, you know, I am still a blue belt, you know, 5 years of training. I just broke a pair of ribs last week. But the reality is about half the men over the age of 40 at the gym are on TRT. Right? That's the half. You know, and let's face it, if you're doing jujitsu, you're not exactly having fatigue. It's relative though, right? Like compared to the 25-year-old power lifter, yeah, you know, you're not going to be the same. But it is, you know, and this is the thing. And as Andrew said, like, you know, I mean, Andrew does CrossFit, I do a lot of jiu-jitsu. I have people talking to me about TRT, like 28-year-olds constantly.
Yeah.
Like literally every week, I'm having discussions. And I mean, you know, fasting levels, all these things aside, really, even if the levels are low, like my concern, if I was even having symptoms, would be that, you know, it's a lifelong commitment to a medication that is, you know, the risks are unknown, right? I think that's the reality. And I think there is certainly physiologically, there is good rationale in people who have low, but you know, I mean, Andrew, as you said, you know, I think even at the beginning, improved lipid levels, yeah, but so did HRT for women, right? And you know, like, so estrogen replacement lowers LDL. But you know, you needed the women's health study, which was, you know, far larger than this one to kind of, and that's fallen out of favor. But again,
Well, don't get me started on the WHI, but that's another story for another time.
there you go.
Yeah. Just being mindful of time here, we should move on because I'm sure people have commitments at 1.
Great. So I'm going to share my screen. Let's see if we can. Does that look okay? Okay, Andrew's muted, but that's okay.
Looks good.
Great. So the study that I'm going to be talking about is the Mind Diet RCT, which is a trial of the Mind Diet, appropriately named because it's supposed to prevent cognitive decline in older people. In terms of the conflict of interest, I actually don't have any. I have never taken any kind of any money from anybody. And in terms of the overall objectives, the things that I wanted to chat about was just to appreciate an evolutionary perspective of diet. Isn't that funny? Also identify neurological and cognitive changes that are associated with aging, and then talk about the neuroimaging findings that are associated with aging, and then talk about the trial. So human diet, something like we all need to eat. I think it's probably the essential part of our existence. And if we look at an evolutionary perspective of the human diet, really, you know, so what we have is, you know, in terms of the human lineage, before the Homo sapiens, the Australopithecus, you know, but really the things that define the Homo sapiens as a species are the use of fire for cooking food. And really, but that was in the setting of the hunter-gatherer for the last couple of million years of evolution, which was in generalized uncooked diet, uncooked meat, and then really cooked meat diet, which is really associated with the Homo sapiens. If you put that into perspective, really the agricultural revolution has really happened, if we're going to be generous, over the last 10,000 years. And that's really made changes in terms of carbohydrate-rich plants, right? The starches. Sugarcane, there's actually great anthropological studies, really has been around for about 1,000 years. And this is the higher availability of simple sugars. And then really over the last 100 years, maybe 200, there's the advent of the highly processed foods. And those are really, from a human evolutionarily perspective, these are really a blink of an eye, but they're incredible changes in the things that we put into our bodies overall. in terms of the evolutionary perspective, the cool thing is that we've been able to, so, you know, you've got evolutionary anthropology, and particularly, we know that we can see cavities, right, of kind of ancient humans and more recent humans. Certainly the hunter-gatherers, really before agriculture, hunter-gatherers had almost no cavities. You know, the highest prevalence was maybe 10% of all teeth containing cavities. Then when you start moving into the agricultural evolution in the last 10,000 years, you start having a big jump in terms of cavities. 50% in the agricultural kind of society would kind of have cavities. Then there's actually really cool studies in terms of small populations that have gotten access to high simple sugars. Sugarcane was introduced in Spain by the kind of the era of the Moor kind of conquerors, and you can see that like the number of cavities just skyrockets in places where sugarcane is introduced. And there's actually a really cool one from 15,000 years ago that there was actually like a sequestered population that was close to these high carbohydrate, simple sugar containing nuts, and they would cook them. And their prevalence, and the cool thing is that their prevalence of cavities was actually very similar to the worst cavity prevalence of all human history, which was industrialized London about 150 years ago. And that was sugarcane import with no dental care, where every single person in like the 1800s London had their teeth rotting out. It wasn't just cavities, dental abscesses and these kinds of things. Obviously, we've had kind of scaling back because of the profession of dentistry, fluoride treatments, toothbrushing, all these things, so that the cavity incidents have actually steadily gone down, even more recently. But this is the incredible kind of changes in the human diet that are really a blink of an eye evolutionarily. They're not really, we're not meant to handle these kinds of things. We know about simple sugars, you know, ultra processed foods, maybe high saturated foods, all these things. And these are the questions: how does this truly affect our metabolism and our ability not just to kind of have energy and store energy, but other essential processes of the human body that really manifest themselves down the line potentially, but are really kind of in process throughout our whole life. The other question is, what are the cognitive changes with aging? In the Mind Diet study, they do talk about cognition. And I think it's important just to kind of have an idea and just review a little bit about what are the cognitive changes and how do we measure them. The Montreal Cognitive Assessment Scale has been around for a couple of decades, and this is just for the sake of, I actually cut it. It's a single page document and test assessment, but it's a 1 page 30 kind of point questionnaire that tests different domains of cognition: executive function, naming, memory, attention, language, delayed recall, these things. And it actually is really good because it does not, unlike other tests such as a mini mental status exam that has a ceiling effect, in other words, most people score perfect, the Montreal Cognitive Assessment is actually more sensitive, so people don't necessarily score perfect. The other cool thing that there's been now studies, especially more recently, is that what is the clinical significance of a change? What's the difference between someone who scores 28 and 26? So there's a study out of Thailand. So in alcoholic patients who abstain for 3 months, their actual cognition improves from 22 up to 24 or 25. So that's kind of cool. In the community dwelling elderly patients, so non-institutionalized, average MoCA score over 65 is about 24 out of 30. This is interesting because when the MoCA was first invented, they actually advocated for the MoCA cutoff of 24 as being mild cognitive impairment. But in fact, you know, the average in the elderly is about 24, again, depending on education, all these things. And it really, cognitive impairment is really, it's not just necessarily an absolute score, but it's also impairment in the function. The other thing that we see in the elderly is that as you age, for every 5 to 10 years, the MoCA decreases about 1 or 2 points after the age of 65. So those are kind of interesting things to think about. What is the clinical relevance of a score? In terms of other types of neurocognitive testing, you know, there's lots of batteries of testing. So for example, the trail making parts A is actually the first part of the MoCA. The part B is again, same thing. So you go, you know, you're going from 1 and then you connect to A, then you look where's 2, there's 2, B, 3, C, so on and so forth, and it's timed, right? So that's how you score it. You actually score the time it takes to complete the test. And then there's other tests. So for example, digit symbol substitution, where you have a digit and you substitute the symbol for it. So again, this is a timed test. How long does it take? Usually about 60 to 90 seconds overall. However, the thing about these neurocognitive tests is although they may be very sensitive in terms of measuring neurocognitive function or whatever domain it is, it's unclear what is the clinical relevance of a change in the score. And that's unlike the MoCA, which we use clinically. We do not use these clinically in practice, and we really are not sure what does it mean that it's decreased, or what does a decrease mean, or in fact, how big a decrease is significant. In terms of age-related neuroimaging findings, especially with the advent of MRI technology, again, 30, 40 years ago, what we started seeing is that there's certain changes with aging. So in the study, what we talk about is these white matter lesions. And what they are is that they're deep matter and really periventricular hyperintensities. They're common in the general public. In terms of how common, we've got multiple studies, population-based studies, cardiovascular health study, a sub-study of the Framingham had 2,000 patients doing MRIs, the Rotterdam scan study, again, about 600. But really the prevalence in the elderly population is 15 to 30%, depending on age, of who has these white matter hyperintensities. What do they mean? Well, pathologically, on autopsy, it's kind of tissue rarefaction. So molosomyelin and axons. So clearly the white stuff, it does not participate in cognitive function. It's kind of broken. It's usually located in deep matter, and it's really often seen in patients with small vessel disease. So the theory is that the etiology is hypoperfusion of white matter, but really, what does that mean? How is it caused, right? Is it that it's actual thrombosis because of maybe endothelial dysfunction? Is it because after decades of high blood pressure and aging, there's a loss of elasticity of small arterioles perfusing the deep matter? Is it things like high changes in blood pressure that then cause a hypoperfusion, although these are not typically in the watershed areas? We don't know. My personal interest in terms of aging or cognition is, because from the neurovision study that showed that 7% of patients who have surgery who are over the age of 65 have silent strokes. These silent strokes, we don't know what causes them, but this is the same kind of pathophysiology possibly as these white matter hyperintensities. What we do know is that the white matter lesions, there's been multiple studies, cohort studies, and they are associated with an increased risk of a new diagnosis of overt stroke, new diagnosis of dementia and death, and about doubling in the risk of these. So then we come to the MindDirect randomized control study. And really this was a two-site study of a dietary intervention for 3 years in older patients who are at risk of dementia. In terms of the intervention itself, it was the MIND diet. And, this is a diet that was kind of a combination of the Mediterranean diet, the DASH diet, and there's all these foods that are, the superfoods. So it's kind of like a superfood diet. Plant-based, nuts, berries, fish, olive oil, limiting in sugar and high saturated fats. This is the MIND diet questionnaire. So this kind of gives you an idea of what are bad, what are good things. They talk about Burger King, Domino's, I have McDonald's, KFC, right? How often do you eat sweets? How many sticks of butter do you eat? These kinds of things. And then, good things. How much fish do you eat? How much chicken? Not fried, skinless. How many tablespoons of olive oil, green leafy vegetables? So this is the idea behind the MIND diet, and this is the MIND diet questionnaire that they refer to as one of the outcomes. So in terms of the study methodology, we had a study population of 65 or older who scored at least 22 on the MOCA, which, to be fair, for that was just a little bit below the average. BMI, they had to be a little bit overweight, BMI of 25 or above. A family history of Alzheimer's disease, had a suboptimal diet, which was according to the MIND diet questionnaire. They had to meet a certain criteria. And then they were excluded if they were allergic to a component of the MIND diet, if they had psychiatric illnesses or substance abuse, or if they had active coronary disease, cerebral vascular disease, they had a history of brain injury, recent cancer, or things like diarrhea or malabsorption from a GI point of view. In terms of the intervention itself, as I said, the intervention is the MIND diet. But in fact, both of the arms of the study received an intervention. There was first a 3-week run-in just to make sure people were able to kind of comply with any diet. They did a food diary, these types of things. And then they were randomized 1-to-1 to either a MIND diet or a mild calorie restricted diet. Now, they had weekly dietary counseling for 6 months and then every 2 weeks for the rest of the trial. And they also had weekly incentives. So they were like mailed like a box of blueberry, like a pound of blueberries, like a bottle of olive oil, and I think a whole bunch of nuts. So literally that was like to their house, or they got a $30 gift card if they were in the thing. So like weekly, so whatever, $5,000 of free food either way, I guess. I don't know whether what happened in the, I know like the actual logistics of this are a little bit mind-boggling. Like, I don't know who delivered the blueberries. I don't know if they were organic. Like these kinds of things were interesting, right? But nevertheless, that was the idea. So it was a very intensive thing. And even the placebo, both in the MIND diet and the placebo, the aim was to eat about 250 calories less to lose a little bit of weight. And that's why they were very intensive interventions both ways. In terms of the study outcomes, this is the thing. The primary outcome was this global cognition score. So basically at 12 neurocognitive tests, they had the trail making B, they had the trail making A, kind of these types of verbal fluency, recall, attention. And then they took a Z-score, which is basically an adjusted score at the end. And they said it's going to be a change in the adjusted score from baseline. Clinically, what does that mean? Nobody knows. They also studied nutritional markers, body weight, as well as a brain imaging and subgroup of patients. Now, they picked 100 patients in each group. The patients were not randomly selected. So there is certainly a bias there. I suspect it was patients who were in one part of the one of the sites and who were able to attend the MRI at the beginning and the MRI at the end. So in terms of the trial results, in terms of the recruitment, there was about 2,000 patients, of which about 2/3 were excluded, so 600 were randomized. 300 to the MIND diet and 300 to the controlled diet, really, controlled intervention, certainly. 300 at baseline, all of them completed a cognitive assessment, and about 1/3 had the baseline MRI. 6 died, and then there was follow-ups. Now, this study did have an interruption during COVID. It was between, I think, March and June of 2020, when everything shut down. But they had continued to do the dietary interventions over the phone. They followed up with everybody. So they actually had no loss to follow-up at 6 months And really out to 24 months, everybody had completed follow-up, which again is in contrast with the other study. And this is what I would actually expect in this study. That was very motivated patients who were screened to be motivated, who were then followed up. So in terms of the baseline data, if we look, patients were about 70, they're all about the same. About a third were men, mainly white people, fairly educated, 17 years. So, you know, that's like, you know, kind of looking at most had undergrad degrees. You know, I mean, baseline cognitive score was 0 because that's their baseline. Their standard deviations were the same. There was more apolipoprotein E4. I don't know what that means. I think that was just a spurious kind of a finding. The rest of them were all same in terms of BMI, their mind diet score. Again, that was the, you know, they had shitty diets. And then, you know, in terms of heart disease, stroke, hypertension, these kinds of things. So they were equal. So in terms of the outcomes, global cognitive scores, again, who knows what this means, but they increased in both groups. Why could they increase? Is it diet? Possibly. I think the other thing that we have to take into account is the learning, right? So whenever you have a neuropsychological battery of tests and you're doing it at baseline, 6 months later, a year later, people are going to remember the trail making test. They're like, oh yeah, that was the one where I connected. You are going to get better. This was not published in the main, this is from the supplement. And that's the body weight. So for both the control and the mind group, they lost weight. How much weight did they lose? It wasn't awful, about 4 kilograms on average. And that effect actually continued. So it was probably about 5 to 10%. And you know what? This is actually in keeping with the typical things that we know from bariatric literature, where very intense dietary counseling in motivated patients is really 5 to 10% of body weight loss. And that's compared with, let's say, 25% of ideal body weight after bariatric surgery, and probably with the new medications, so like semaglutide, 10 to 20%. It's actually fairly remarkable. But that's the comparative. Nevertheless, this was lost without any interventions in terms of pharmacological, surgical, and that was sustained throughout the 3 years, which is really good. If we look at the mean level of antioxidants, so this is what the nutritional markers were: lutein, alpha carotene, beta carotene. You know, they're statistically not significant. They go up and down. People were not getting deficient. I suppose that's a good thing. They were not massive increases in the mind-body group, and the mind-diet group is the black. So it's not like they went, the lutein went up a little bit. Again, still not statistically significant, but it's not like they were through the roof. In terms of the brain imaging results, there was no difference. What they looked at was white matter hyperintensities, both the baseline and so basically 97 out of 103 patients, 96 out of 100 and whatever patients had white matter hyperintensities. And I mean, that's not altogether surprising. It's a little bit more frequent than you would expect. But obese patients with crappy diets have, and this is not something that happens overnight. This is something that's been going on for decades. So, in terms of hippocampal volumes, there is a mild or minimal decrease, both not statistically different between the two. In terms of gray and white matter volumes, again, a small decrease. This is probably what we expect with aging, but quite frankly, there's not that much literature in terms of longitudinal things. The interesting thing about this is that if I were doing the study, I would not have done the baseline. The only reason you would need a baseline in the study is if you expect that there is not an equal randomization or proper randomization, because the randomization itself should have controlled for known and unknown confounders. So if you have two groups and then you had reasonable sampling of who's going to have the MRI, or quite frankly, if you were limited by cost and you could only do MRIs, they shouldn't have done the baseline MRIs. They should have just scanned everybody at 3 years and then compared between groups, not from baseline to year 3 change. I think the reason they did the baseline to year 3 change is because they specifically say in the study that was non-random sampling of the people who got the MRIs. I think that was the people that were willing. Again, in the neurovision study, it was the same thing. The problem is that if you have people with incident dementia, you worry that they're less likely to attend appointments. So you're biasing against people. So for example, let's say the diet really worked well, and nobody in the intervention had incident dementia or cognitive decline, and a whole bunch of people in the control diet had cognitive decline. Well, people who have incident dementia with cognitive decline, you have decreased motivation, you have increased risk of depression, you have decreased ability to kind of get around, decreased function. So as a result, these things may impede the fact that these people may not get brain imaging results. Nevertheless, in terms of the critical appraisal, I use the CAST RCT assessment, which looks at, are the study results valid? What are they? And will they help us? Are they valid? I mean, the population, the intervention, they're clear, and the randomization seemed good. The brain imaging subgroup was not randomly selected. Again, most patients were accounted for despite the challenges of COVID, and for the data that was missing, they imputed it. They did the sensitivity analysis without the imputed data, so I think that's a reasonable thing. Obviously, the patients are not blinded whether they ate the blueberries or not, but outcome assessors, clinicians were blinded to the randomization and the allocation. And the groups were treated equally except for the intervention. But again, the control group was not standard of care. They were very intensive compared to what we usually do. What are the results? Essentially, there's no difference. There's no difference in the global cognition. There's no difference in weight loss between the two. No difference in nutritional markers, no in the brain imaging. Will the results help our patients? I mean, let's say there is a clinical benefit. You know, there's certain things that we do need to consider. This was a very USA-focused intervention. The Mind Diet questionnaire would be totally meaningless in a place like Croatia, where there's like no McDonald's, or certainly Burger King or Popeyes or whatever, right? So I think that kind of a questionnaire probably should be a little bit different. We have to ask about, I don't know, Chibati and Burek or something like that, right? The clinical outcomes, I think the problem is that primary clinical outcome, which is this global cognitive score, you don't know what to make of it. I don't know what a change in 2% is. I don't know what a change in 5% is. The dietary counseling is not applicable. We could not possibly do weekly interventions and mail patients blueberries. It is not possible. It is an interesting proof of concept, but it is not possible on population level, certainly not for any individual for any individual clinician. And quite frankly, you have to wonder about the availability and patient cost of food items. Even if you tell patients that this is what they would need to eat during the winter, how many blueberries do we get? Costs, all these things. I think these are serious things to consider. You know, if the treatment effect was significant, I think in that case, as a society, we would have to look at this. But overall, I would say I'm not so sure that even if there was a modest benefit, that this would be a possible intervention. In terms of discussion, again, I don't know what the rationale behind the intervention was. In terms of, you know, why did we choose blueberries? Why did we choose not one of the established diets? I think we need to, you know, that's my thoughts. Components of the intervention, again, the intensive counseling, it would be so hard to implement that, and really in the standard group, why would we implement this is the difficulty, is that I'm not sure that this was a realistic thing overall. Who is the target population? If we have a patient who's already 75, who has had a diet that they've had for 75 of their years of their life, I think it's very difficult to make a meaningful change in terms of even cognitive outcomes. I think it's difficult to reverse the pathophysiological processes that led to that, even if we know what they are. And again, it comes to the same thing, which is the duration of follow-up. Really, for a dietary intervention, when is the optimal time to intervene? Is it at the age of 75? Is it at the age of 40? Is it in school? Or quite frankly, is it from birth and looking at a societal intervention?
I was just gonna say that, Marco. I was like, I think the ideal time is when you're a child and we create the good nutritional habits that you'll maintain throughout the rest of your life. Because unwinding people's diet behaviors is exceptionally difficult and complex. And it's, yeah, very, very challenging. But like when I read the study initially, I was not surprised whatsoever that it was a negative trial, because just reading it, you're like, this is a trial that was designed to not show a difference from the beginning. So like if they were, and it's wild because it's such an intensive intervention and would have cost a lot of money. Like, why did they not choose a population that already had mild cognitive impairment? Like, it doesn't make any sense to me. You're like at risk for it.
Yeah, I mean, Andrew, the issue is that I think if you have mild cognitive impairment, the idea is that it's already out of the box. I think honestly, the people who did the study were like true believers in the power of superfoods. They're like, this is going to, like, the pound of blueberries. Literally, they mailed them a pound of blueberries. They're like, the pound of blueberries is going to prevent these people from having like mini strokes.
Because it's been done, right? So like Med, which was the Mediterranean diet trial for patients with cardiovascular disease, which was a positive study. Like they literally sent them a gallon of olive oil every week and a whole bunch of nuts every week. And like it's amazing, but for sure, like the pragmatic application of this in the real world, it's just not there. It doesn't make any sense. It's interesting that you've created a new diet, the Mind diet, which is just a combo of Mediterranean and DASH, which are almost exactly the same to begin with a few exceptions. So like the DASH diet doesn't include a glass of red wine every day, and not as much olive oil. And the DASH diet's maybe a little more aggressive on the sodium reduction. So both have been shown to have benefit. It's just that the Mediterranean is more like, if you're in Europe or Spain, then you choose Mediterranean. If you're the AHA and it's a US centric, then you choose the DASH diet as the most cardiovascularly healthy one. Maybe this was like a bridging of the European Cardiovascular Society and the American Heart Association. I don't know.
I mean, that's exactly right. I mean, the wine thing, even like the glass of wine a day, the old Italian grandmother trope is really probably not helpful. But I think these people were true believers, that there is a food that could actually quickly, because really, they quickly reverse and potentially improve cognition. And unfortunately, it did not pan out. Right?
But you think that like the outcome of this, it actually risks making it more complicated for people to just say, oh, well, these diets don't work. Whereas no, like people lost 4 kilograms. That's, so when you restrict calories and you adhere to a calorie restricted diet, like you lose weight. And we know that that's associated with all sorts of good things. It's just that it doesn't necessarily line up with a made up bunch of neurological tests with no clinical relevance. Like that's almost sort of beside the point.
It's interesting, again, if you believe that there was a superfood and you're like, you know what, the mocha is not going to be sensitive enough, that's what you would do. It's very interesting. I mean, the other thing is, again, meaningful study outcomes, the surrogate outcomes of neurocognition, imaging, biomarkers, I think, is difficult. And then what are the meaningful outcomes? To me, it's functional outcomes, it's clinical outcomes, right? Functional in terms of, if you want ultimate functional, would be placement independence, right?
Yeah.
These are long-term outcomes that are, anyhow. And then because of the COVID, this was my last pre-COVID selfie. So literally the toilet paper riot started as I was coming home, like as we were getting off the hill. You got it came down, but yeah.
Amazing. Any other questions or comments from the group?
I was hoping for some input in unwinding my Sour Patch Kid addiction, but this has not helped me at all.
You probably have 100% T2 hyperintensities.
So just to be clear, are you actually serious? Like you actually have like a Sour Patch? Oh, because that would have been fun.
Yeah, no, it is the North American diet that is the reality-based medicine challenge of our time, though.
Yeah, totally. And you know what's just super frustrating on top of all of it, because I talk to people a lot about diets. People have no idea what they eat.
Yeah.
Like you can have a conversation, you can do a 24-hour recall. It's completely inaccurate. Because when somebody actually does change and adhere to something, they're like, oh, I didn't realize that I was, having these snacks in between, or I was just mindlessly doing this while I was making dinner and blah, 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 and on and on. And somebody brought in the muffins to the lunchroom, and so I ate 5. Like it's really, really challenging.
Absolutely. And this is the thing, and it starts from childhood, right? And this is the crazy thing. Like the habits start from childhood, and the pathophysiological consequences probably start in middle age, whatever that is. It's 40 or something. And then you look at the outcomes. By the time that train is rolling of whatever the combination is, endothelial dysfunction, high oxidant stress, procoagulable state, who knows? Like you're not reversing that with a 3-year dietary income when someone's 65 and these things are already gone.
Cool.
So
all right. Well, I think this was a tremendous success. I thank everybody for joining, and we'll be in touch with future dates to come.
Yeah, just in terms of questions, Russia asked why they had people with a BMI of more than 25. The concern with the restrictive diets, I think, is that if you have someone who has normal weight, is malnutrition, which can be just as bad and, quite frankly, is just as severe in the elderly as being overweight. Same prognosis in terms of association with mortality. That's why, and I think their interventions were to have a calorie restricted diet, which again, you do not want to have elderly who are being malnourished, I think. Sorry, Andrew.
Fair point. Yeah. Okay. Awesome. So we'll be in touch with future dates, and we'll let you know when the recording is posted. And enjoy your afternoon.
Thanks. Cheers.